Hello, welcome to the Healthcare AI weekly broadcast on machine learning in healthcare. Stoked to have you here with us today. My name is Taylor Miller. I'm on the data science team here at Health Catalyst, and I've got a great topic today. We're going to be talking about the opioid epidemic. Before we get into our guest, who we're excited about, we've got a couple PR things to mention. If you go on to healthcare.ai, if you log into YouTube, you can then chat questions to us. We would love to have some interactivity and some questions on this topic. Also, while you're there, you can hit subscribe, and that will notify you every week when we have a broadcast going live. And another thing we would love is we've set up a Slack channel, which is an instant messaging platform. It is no cost to you. Hop on healthcare.ai and subscribe to our channel. And we've got a growing community of analysts and experts and clinicians that you can ask questions to and discuss things with. So, and one last thing, for those of you out in this community who are interested in really upping your machine learning skills, we have our Healthcare Analytics Summit coming up in September. We have a 2-day course on machine learning, which you can find out more about on our website. Without further ado, let's get going. So today we are talking about the opioid epidemic. We have with us today Dr. Anthon Lemon, who is an emergency medicine physician, board-certified emergency medicine, also in the United States Air Force. Go ahead and introduce yourself for a moment.
Hey, I'm Anthon Lemon, like you said. I have a background in nursing. I went to Purdue University, graduated from there back in 2008. Then went to a military medical school, USU, out in Bethesda, Maryland. And then I finished my residency training in Ohio, Dayton, Ohio, where I finished my residency in 2015. I've then since moved to Las Vegas and deployed once with the military in 2016 to the Middle East.
Great. Because this is a topic that Dr. Lemon and I are so passionate about, it's important to note that we are going to express some opinions here. Those opinions are not representative of our respective employers. Those are our personal opinions. So that's important to state because we're going to get into a topic that we both feel very passionate about, and that is the opioid crisis. So we'll just start out for those in the community that may not understand what this crisis is. Let's start with the very beginning. So what's an opioid? Would you mind filling us in on that?
So an opioid is a narcotic medication that is used for pain control. It has basically pure pain control properties without getting too detailed. So it doesn't really tackle any of the pathology that might be causing pain. It just kind of tackles the pain receptor in the body physiologically.
Correct. So it's not an anti-inflammatory like the NSAIDs or ibuprofen. It just deals with blocking the pain itself. So why do people abuse opioids?
Opioids, because of their probably their central nervous system effects, can create kind of a higher kind of a dysphoria that people enjoy. You know, there's an abuse potential because of the psychological dependence, the feelings that people get from these opioids. There also over time becomes not only a psychological dependence and tolerance to these medicines, but a true physiologic dependence and tolerance to these medications. So that's really why they can become abused.
Absolutely. And it's always important to discuss for people who may not be aware of the very specific definitions, dependence versus an addiction. And the easiest way I like to think about that is a dependence is the body's kind of need for something to maintain some kind of normal state. But addiction is, on top of that, a person who has a true addiction goes and has behaviors that are harmful to themselves or others to support that dependence. And we'll be talking about some of those things today. Let's talk about the scale of the opioid epidemic. And that phrase was coined by the CDC. And I've got an article here that we will post later. I'd love to show you. And it's by the New York Times. And this is a really phenomenal way, if you're not familiar with the scale of this problem, to kind of understand it. So what they do is they have some graphs. Okay, so starting at 1990, the number of Americans who have died every year from car accidents. And you try and plot this out and see, oh, I don't know, I imagine cars are getting safer. Show me how I did. So these have declined slightly, and this is just to help you get a sense of scale. So in the United States, we think a lot about gun deaths and we think a lot about car deaths. So those are the two that we're going to compare the opioid crisis to. So what about guns? And we'll probably leave that one as a mystery for our community, but let's just show you. So, a dip, slight increase, but relatively stable since 1990. What about the HIV epidemic? A big burst in the 90s and is definitely tapered off now that we understand that disease and know how to control it and prevent it and so forth. Now you'll notice this graph, you can kind of cheat on this graph because they have a ton of upswing in area here. So from 1990, approximately 8,400 people died in the US from drug overdoses. Well, this number has climbed and climbed and climbed and climbed and climbed somewhere in this territory. And as of 2015, some 52,000 Americans have died of opiate overdose. And it's just really interesting to see. I'd highly encourage you to dive into this article and understand how drastic of a change that is relative to other causes of death that we consider severe in the U.S. And I would probably like to spend a minute with hearing Dr. Anthon's perspective during his residency in, I think it was 2015?
Yep, when I finished, correct.
Yes. So when he finished his residency, he was in what part of the country, Dayton, Ohio, that at the time had a particularly bad problem. I wonder if you can tell us some stories about that time or what you learned.
So there was a lot of, namely heroin overdoses and patient presentations related to the heroin epidemic, but prescribing opioids and overdoses related to those prescribed opioids in overdose presentations were kind of in parallel. I rarely worked a shift where we didn't deal with what we kind of lovingly call the homeboy drop-off at the door. And these people would come in not breathing, they basically were on death's door. And it was, a fight against time to try to get them back. And what's crazy is we're pretty good at reversing the effects acutely. And these people would oftentimes come in essentially, dead, and we'd get them back with a reversal agent called Narcan, and they'd oftentimes walk out of the ER. Rarely actually did they actually need or require an admission to the hospital. However, that being said, these addictions, prompt, people to do things and find maybe less reliable drug dealers if there is such a thing. And we were finding that that some of their suppliers were, lacing some of their typical doses, so to speak, and what they would take in heroin. And they'd be laced with things like carfentanil and things that were much more potent. These people would end up either dead or on Narcan drips and requiring ICU admission stays and have global anoxic brain injuries. I mean, this would literally change their life if not take it.
Yes. Well, that's stunning just to see that perspective of not a shift going by without one of these types of cases. That's amazing. And certainly it bears pausing for a moment and talking about a lot of us in the medical community view an opioid as an opioid, whether that's a prescription opioid, OxyContin, Percocet, hydrocodone, all these that are prescribed for chronic pain. But can you talk for a moment about the transition for people between, maybe they started out with prescription opioids and transitioned to illegal opioids?
How do I perceive that happens? Is that the question? Yeah. So I think oftentimes people begin their journey, so to speak, into opioid addiction with real pathology, a big fracture, long bone fracture, or some kind of post-surgical course where they had their gallbladder out or their appendix out. And I think that tends to devolve, because I think it becomes where, it wears on not, the providers as well. They see, they kind of, I think they see the slide happening. Um, but physicians, we've all kind of gone into the profession to help patients, and patients now come to us requesting um, more narcotics, specifically by name oftentimes. And they say, well, my pain's just too bad, and ibuprofen doesn't work, Tylenol doesn't work. So, you know, I think that kind of snowballs, and then prescriptions become prolonged, and then
Mm-hmm.
the addiction and the tolerance starts to kick in. The need for higher and higher doses starts to kick in, and then eventually it's probably picked up that this is really truly a problem. And then when you pull the rug out from underneath these patients, they find alternative methods
Right.
to getting their opioids, whether that be from diverted prescribed opioids or whether that's from illegal sources like heroin.
Right. Yes, and just a couple definitions for those who may be less familiar. Diversion is the process of legitimate prescriptions being diverted for illegitimate means. And I can definitely think in my practice as a pharmacist of patients who, started off similar situation, pain needs to be managed and it needs to be treated. And for whatever reason, that became a dependence and an addiction. And particularly during the time when oxycodone was being reformulated, it came back on the market far, far, far more expensive for patients. And I had patients who still needed to fulfill that addiction and could no longer afford prescription medication, so they went to other means as well. And it's important to see that it's not a black and white situation. It's a spectrum of drugs of choice, and those come and go. We're seeing a lot now in the news about these very high potency opioids, fentanyl, carfentanil, and these are typically in a medical setting only used for the most extreme types of pain, chronic pain patient. And now we're seeing these on the street. We're seeing more and more stories of enforcements. A police officer will pull someone over and inspect some bag of powder and end up dead because this stuff's so potent that there's no time for reversal. So I would like to talk about what kind of approaches have you seen that of attacking this problem? It's such a big problem. Where do we start?
Yeah. So the most notable, I would say, are the state implemented prescription monitoring programs. These are databases. Um, some of them, to my knowledge, will talk to other states, but they're somewhat tedious. They require specific logins for the prescribers so that they can, go onto specific websites and then log in, and they have to kind of find patient data, first, last name, date of birth kind of identifiers.
Mm-hmm.
And then they'll come up with a report that basically displays to the physician who's prescribed the patient a scheduled medication. So which providers, which pharmacies these patients have obtained scheduled medications from. That process is fairly tedious, but it can be helpful. It depends on what the report shows, but we tend to look for things like multiple physicians, multiple pharmacies. These patients are kind of displaying a pattern of a drug-seeking behavior, when that happens. So those are the kinds of things that we look for. Other things specifically to mitigate, not per se the addictions, but to try to mitigate the deaths
Mm-hmm.
caused by the addictions, are things like Narcan reversal kits. These are in my residency we were beginning to implement these reversal kits, and we would actually provide teaching
Mm-hmm.
to not only the patient but to family members that might present with the patient, because oftentimes the patient we were seeing, they were likely
Right.
going to be the person that would overdose, and thus the family members, the friends, might have to be the ones that would administer the Narcan to save a life.
Yes. Yeah, so you've mentioned a couple things that I want to add something to. One of those being these state-run prescription drug monitoring programs, and these vary widely across the gamut in terms of data quality and data access and speed. Some states ranging from requiring pharmacies to report to these databases once a month, which is not going to help, frontline practitioners at all the way up to weekly, to daily, to live. And that varies from state to state. And there's particular problems when you live in an area that borders a state. And typically, at least in the past, those state programs have only been accessible to providers in that particular state. Now, more and more, we're seeing states close by collaborate so that you could hop on and I could see, okay, my patient went to Nevada and to this pharmacy, but now they're in Utah filling again 3 days later, and those kinds of things help a lot. The other thing that is worth mentioning is I feel pretty strongly about the importance of those naloxone reversal kits, and if you're not aware of those, go and read about them. If you have family members or loved ones who have addictions, go to their doc and get a prescription for these, because these are seriously life-saving devices. So definitely important to think about. I'd like your perspective, Dr. Lemon, on some of the challenges of doing this in a high-pressure, high-volume ER. What kinds of things do you run into?
Yeah, so with a lot of, I every time I see a patient, they're an undifferentiated patient that might have potentially acute surgical, emergent, or life-threatening pathology. And I have to treat and approach every patient encounter that way.
Yes.
With no previous knowledge of where they're coming from. So literally within seconds and minutes, I need to try to tease out the patient's past medical history, their surgical history, their drug allergies, the medications they're currently prescribed, their comorbidities, and their presenting illness, their history of their presenting illness. This is all a very quick process in a fast-paced emergency environment where you're seeing patients that practically line up at the door sometimes. Both walk-in and ambulance traffic can show up 6 at a time. These patients oftentimes, are just so overwhelming to the physicians where, many of them require acute resuscitation, others look stable. So there's a whole triage process that goes into that as well. And then to add on top of that, expectation or requirement that you also look at old records and, previous prescribing patterns and et cetera through these databases is tedious. And I think we all, struggle to try to keep up with those expectations. So, I may be tied up at the bedside, intubating a patient, putting in central lines, doing bedside focused ultrasounds and coordinating patient care, talking to consultants, to try to manage people that are on death's door, and that's for a variety of issues, all while simultaneously trying to manage these chronic pain patients that are coming in 2-3 times a week, sometimes multiple times a day, and these patients really go to pretty extreme lengths to try to obtain their narcotics, oftentimes going, I found, from one hospital directly to another, trying to find these narcotics. So, it's hard to keep up on all of that, especially when the prescribing monitoring programs are not accessible readily at just a couple keystrokes in the computer systems or that I'm in, when I'm managing a patient.
Absolutely. Yeah, and from a very similar story plays out in pharmacy that, they're different depending on your state. There's different regulations depending on your organization or your policies at your workplace. We certainly tried our very best to check for certain classes of medications. We would try to check these prescription drug monitoring programs and look at past history. But again, it's all about a similar situation. You have high volume situation. I've got to prioritize my time as best I can to help all my patients be as healthy as possible, and sometimes that gets left out, and that's very difficult. There was sorry, go ahead.
Oh, I was just going to say, and because of that fast-paced, busy environment, there's limited time for teaching. But when I do have time, I really like to sit down with these patients because I truly believe they're in pain. but I do try to help them understand what's basically happened to them physiologically. And what's happened, these medicines over time upregulate their pain receptors. And I explain to them it's like having smoke detectors that are going off that are, just because you're cooking on the stove, they have oversensitized pain receptors. And because of that, to saturate those pain receptors and to obtain pain relief, they require higher and higher doses of these opioid medications. And that increases their risk for side effects, respiratory depression, all the bad side effects with really uh, dwindling pain relief. So
Yes.
I tell them the only way to try to turn that around is to get off these narcotic medications.
Mhm. And it's tricky because we definitely, there's lots of studies that show that pain is a very, very intense driver, and it's in as this pendulum swings in healthcare, this slow pendulum. There have been times when we have undertreated pain as a system, and times when we've overtreated pain too, and it's hard to strike that balance, particularly on an individual patient level. Um, so what we'd like to do today is to think about, from a lot of our community is analysts and data people and executives. We'd like to try to brainstorm and start a discussion about what are some other approaches that we can start to take. And there have definitely been in practices some validated tools, very short questionnaires, and that you help you assess a patient's risk, as it were, of addiction, and those can be helpful. But again, that's one more thing that's probably out of the provider's normal workflow that takes them out, and if it's not in your workflow, it's very difficult to do it. And the other thing that we'd like to talk about for a few minutes is just the challenges of data access. Many these state programs are great, but those are only for practitioners and regulatory bodies typically. So that isn't something that most data analysts have access to, and it's a very retrospective rather than a prospective approach. The other data sources we could think about might be there's lots of data buried in text notes in your EMR, and that's difficult to get at with our current technology. And we might look at the payers because they have a lot of information. Most payers are not super keen on sharing their data because that's effectively their gold mine. And so healthcare is fraught with these data silos, and we'd just like to kind of open this discussion to the community and think about, all right, what data sources do we have access to that we might be able to build predictive models on specific patients, so we can give those predictions to frontline providers to help them with their workflow. I wonder if you could talk for a moment about what kind of workflow you could imagine that would make this problem a little easier.
Yeah. So I think in my context, how many patient presentations to an ER, have they had? Now, that being said, I know that the primary care world has a lot of difficulty, and a lot of people have difficulty with access to their primary care doctors. And so
Absolutely.
emergency medicine providers, despite the fact that we are not primary care physicians in the sense that we do not provide continuity of care, we kind of become these patients' continuity of care. So that's one red flag. Although I understand that there may be some instances where patients kind of overutilize the emergency room because they can't gain access to care. But many of these overutilizers are patients with drug-seeking behaviors and such, and with unobjective pain complaints such as headaches, such as dental pains, nonspecific belly pains, with numerous workups that have not revealed any objective pathology. So that's one red flag. I think identifying prescribing patterns where patients are obtaining prescriptions from multiple providers, where they're obtaining prescriptions from multiple pharmacies. These are all things that would be very useful in my clinical decision making. However, if I have to data mine and try to find and elicit that information myself, it's going to be very difficult. So having kind of I guess, as much as I hate to say it, but a push notification at the time of prescription, when I'm actually entering in that prescription, that tells me some of these red flag items potentially might deter me from prescribing a narcotic. One thing that I think emergency medicine in general has kind of started to do culturally is prescribe very short courses of
Mm.
opioids. I mean, 2-3 days, and that is it. We generally do not prescribe or refill chronic pain medicines. If any patient comes in and endorses a chronic pain syndrome, because inevitably they come in on a Friday afternoon when the clinics are closed now for the weekend, and they've ran out of their medication or they've
Right.
lost their medication. And so, I mean, these are the red flag things that we see all the time, but we've just kind of taken stances and policies that we do not refill chronic medications that are scheduled. So we try to find creative alternatives. I try to find creative alternatives to their pain control. But when I identify these things, I try to also make some time to sit down with the patient
Yes.
and talk about my concerns. And those conversations are hard. It's like telling your kid that wants cake for breakfast that cake's not the best thing to eat for breakfast,
Hmm.
right? And then you have these institutional and surveys and reimbursements attached to Press Ganey, customer satisfaction, so to speak. So you have this little carrot of make the patients happy and
Right.
we'll actually pay you more, or you'll be reimbursed better from the CMS and the Press Ganey kind of metrics and JCO regulations. However, good healthcare does not mean patient satisfaction. I mean, it just doesn't. And to try to
Absolutely.
make this into a customer service philosophy is not necessarily the right thing, because it's not safe per se to just give patients what they want. Patients sometimes want what is not best for them. That's why we go to a decade plus of medical training to do what we do and to get our prescriptive authority. To be that paternalistic kind of approach in medicine, I think is it's important, and it needs to be respected. And to have customer satisfaction thrown into the mix is probably not a good idea.
Mm. Yeah, that's a really interesting perspective. And one of the things that you said that really struck a chord with me is that, um, this is there's a lot of finger pointing in healthcare about whose fault is the opioid problem. Oh, it's the prescribers. Oh, it's the dispensers. Oh, it's the whatever it is. It's big pharma. There's lots of finger pointing, but this is really a problem that all of us have to solve together. Our what our goal is to start getting the data professionals tools and access that they need so that they can join this collaborative effort. But there's one article I'd like to just briefly show you. Brand new. Well, I guess it's not brand new. It's 2015, and this is one of the few machine learning pain. Okay, we're having some computer trouble, but we will stick it out in the Slack channel later. But there are a very few groups working on this, and it's pretty exciting that what I'm trying to say is this is a very individual problem, and wouldn't it be great if the data professionals could get together with the clinicians and help them prioritize their time so that you can do that education with that patient who you might really be able to impact and help prioritize. I think one of the challenges with healthcare, and one of the is that it is a lot of priority decisions. I mean, practitioners make decisions every day, and it's about prioritizing. Because we have limited resources in this country, we are burdened with the amount of care that we have to provide, and we have to make those tough choices. And as a nation, it's very easy to get into those discussions and turn them in such a way that it's death panels and it's so forth. But really, it's about, look, we have finite resources. We've got to prioritize those. So if we as data professionals can help prioritize in any way, we would love to help contribute to this healing the nation from these kinds of wounds. Any last thoughts on opioid epidemic you'd like to share with us?
Yeah, I mean, I think opioids have a role, just to be
Absolutely.
clear, because, I think it's easy to bash opioids. Opioids have a role, and patients have real pain. And I want to make it clear that, all the patients that come to me, despite the fact that they may display drug-seeking behaviors, addictions, pathology as well, and I think we need to help these patients. We need to find creative ways to help these patients. I think, that paternalistic approach to managing them, I think I just like the foot stomp because, we need to remove the expectation that the patient walk away happy. Sometimes patients aren't going to be happy. I think every effort should be made. I think the whole, a big part of why this pendulum has gone back and forth is because initial kind of um, well-intended efforts and kind of making pain a fifth vital sign and those kind of things. I think it was all intended to try to enforce, and encourage patients to assess pain and to address pain. And I think it's important to do that. But I'll tell you, I've never known a patient to die from pain. There's a lot of people dying from the things that we do to manage pain. So we need to address pain. We need to find ways to address pain, but we also need to find the appropriate rules for opioids in pain management, and we need to limit their utilizations to very short times, very short courses, and then find other creative ways to manage patients' pain. So, I'm hopeful to see, this trend reverse. I'm a little discouraged anecdotally from where I trained in residency, just seeing the heroin epidemic skyrocket. Really, in the last 5, 6 years, I think it really is taking off. And those people, when they have issues finding their suppliers, they're going to try and get prescribed narcotics, and they're going to find creative ways to try to do it. So, I don't want to be a legal drug dealer for a patient. I want to manage their pain and help encourage well-being for patients. I just don't want to. I want to do it in a safe way. So, having good ways to help the clinicians make those bedside assessments, I think, is a really great way forward.
Absolutely. Well, we really appreciate you coming on and helping us get a glimpse of how complicated this problem is. And there's so many approaches to this problem. We're excited to begin this discussion in our kind of analyst world and how we can help as analysts and executives in making these decisions to help these patients and help out. So thanks again for your time.
Yeah,
We'd
you're
love for additional questions. Hop on the Slack channel, and we'd love to talk more about opiates and how those are being discussed. Apologies, we had some technical support, so I did not get to answer questions that were in YouTube, but we do want to thank those of you there, and hop on Slack if you're not, and we will be able to address those. Thanks again. We'll see you next week.